Welcome back to the deep dive. Today, we are tackling really a massive topic, the core principles of oncology. And this isn't just scratching the surface. We're aiming for a proper deep dive into the foundations, the structure, the molecular reality of cancer. And we're using, well, a foundational text that many of you will know for revision and practice. And, where better to start than right at the beginning? We're talking 4 centuries before Christ. Hippocrates, often called the father of medicine, he's the one credited with coining the term cancer.
Yeah, and the word itself, from the Greek karkinos, meaning crab, it's quite a vivid image, isn't it?
It really is. Those finger-like projections of a tumor, reminding him of a crab sort of burrowing into the flesh, unsettling.
It's an image that's stuck. But thankfully, our understanding has leaped forward. I mean, the source material we're digging into today puts us squarely in the molecular era. We're way beyond thinking about, divine intervention or bad humors. Cancer is fundamentally a disease of abnormal cell proliferation.
Right, and that groundwork was laid way back, wasn't it, Rudolf Virchow?
Exactly. Virchow's famous dictum, omnis cellula, every cell from a cell. That simple idea meant cancer cells had to come from existing cells. It set the stage.
And then the 20th century just blew it wide open.
Completely. You had Bovary noticing weird things with chromosomes, Oswald Avery nailing DNA as the genetic stuff, and then, of course, Watson and Crick giving us the double helix structure. All that together allowed us to finally ask how cells go wrong at the molecular level, which is, well, the basis for pretty much everything we do now in treatment.
Okay, so that's our mission for this deep dive, to walk you through that whole landscape. We want to give you a really comprehensive, structured understanding of the biology, the causes, the management principles. Think of this as a solid framework for your revision, something you can really use. We'll start right down at the tiny scale, the cell itself, and the rules it has to break. So the big question, the core scientific puzzle, how does a normal, well-behaved cell, one that plays by the rules, transform into this aggressive rogue cancer cell? It's not like flipping a switch, is it?
Not at all. It's more like a criminal career path, acquiring a set of illegal skills over time. Robert Weinberg and Douglas Hanahan famously called these the hallmarks of cancer. It's basically the checklist of abilities a cell needs to survive, divide when it shouldn't, invade tissues, and eventually spread.
And if it misses one?
Generally, the whole enterprise fails. If a cell can't, say, evade the self-destruct signals, it won't become a clinically relevant cancer. So the first, maybe the most fundamental hallmark, is achieving what's called an autonomous lineage, basically sustaining proliferative signaling.
Meaning it doesn't wait for permission to grow anymore.
Precisely. Think about normal cells. They only divide when they get specific external signal growth factors telling them to, maybe after an injury or hormonal changes. It's tightly controlled, like having both an accelerator and brakes. Cancer cells, though, they kind of hotwire the system.
How do they do that?
Well, they can make their own growth factors, or maybe turn the receptors on permanently so they're always getting the signal. More often, though, they get mutations inside the cell, in the signaling pathways downstream from those receptors. It's like the accelerator pedal gets jammed down.
And this is where oncogenes fit in, right? These mutated driver genes.
Exactly. Oncogenes usually start life as normal proto-oncogenes, genes that do important jobs controlling growth and differentiation. But if they get mutated or maybe massively overexpressed, they become these oncogenes, driving that uncontrolled growth.
And the scary thing is the timeline you mentioned. These changes can start way earlier than we think.
Oh, absolutely. Research shows that the very first founder mutations can pop up decades before anyone gets diagnosed. A person might be walking around with cells genetically primed for this autonomous growth long before it becomes a detectable tumor.
Wow. And it's rarely just one bad gene, one mutation. It takes more.
That's a crucial point. One mutation, like activating an oncogene, usually isn't enough. The cell still has its safety systems, its brakes. It typically needs multiple hits. The classic example everyone uses for revision is colorectal cancer progression, based on Bert Vogelstein's work.
Right, the step-by-step model.
Exactly. It shows this sequence. Maybe lose a tumor suppressor gene first, that's like cutting the brake lines, then activate an oncogene, then maybe lose another suppressor, and so on. Often, the order in which these mutations happen matters too. You need that critical accumulation to really push the cell over the edge into full malignancy.
Okay, so the cell's lineage is established. It's growing without permission. But normal cells have a lifespan, don't they? They can't just divide forever. That brings us to replicative immortality.
That's the next major hurdle they have to overcome. Normal human cells, most of them anyway, follow the Hayflick hypothesis. They have a built-in limit, maybe 40 to 60 divisions, and then they stop. They enter senescence or die off.
And that's tied to the ends of chromosomes, the telomeres.
Precisely. Telomeres are like the protective plastic caps on shoelaces, stopping the chromosomes from fraying or sticking together. Every time a cell divides, those telomeres get a tiny bit shorter. Eventually, they get critically short, and that signals the cell, okay, time's up.
So how do cancer cells get around that?
They cheat. They reactivate an enzyme called telomerase. Think of it like a molecular repair crew that comes in and rebuilds the telomeres after each division. By switching telomerase back on, it's usually off in most adult cells. The cancer cell line bypasses that Hayflick limit. They achieve immortality, at least in terms of division potential.
Divide forever, grow without signals. But they still have internal quality control, right?
Yeah.
Ways the body gets rid of faulty cells. That leads to evading apoptosis. What exactly is apoptosis? It sounds different from just dying from injury.
Oh, it's fundamentally different from necrosis, which is messy cell death from trauma. Apoptosis, the word comes from Greek, meaning leaves falling from a tree. It's this incredibly neat programmed cell suicide.
Programmed suicide.
Yeah, an internally driven process. The cell gets a signal, maybe because its DNA is too damaged or it's just not needed anymore, and it activates this cascade. It shrinks, the DNA chops up, the whole cell fragments into these little membrane-bound blobs called apoptotic bodies. Then neighboring cells just gobble them up cleanly. No inflammation, no mess. It's essential for development and getting rid of potentially dangerous cells like precancerous ones.
And cancer cells have to disable this system.
They absolutely must. They need to find ways to ignore or block those QME signals. This is where tumor suppressor genes come in again. The most famous one is P53.
The guardian of the genome.
That's the one. P53 monitors the cell for DNA damage or other stresses. If things are bad and can't be fixed, P53's job is to trigger apoptosis. So if a cell mutates or loses P53, it loses that critical safety check. A damaged cell that should have died is now allowed to survive and keep dividing, mutations and all. That's a massive step towards cancer.
It sounds like a prime target for therapies trying to switch P53 back on somehow. Okay, so cell is immortal. It ignores kill signals, but it can't grow big without supplies. This must be where angiogenic competence comes in.
Exactly right. A clump of cancer cells can only get so big just by diffusion, nutrients in, waste out. The physical limit is tiny, maybe 1 millimeter across. Beyond that, the cells in the middle start starving. They don't get enough oxygen. The tumor basically stalls in this dormant microscopic state.
So it needs a blood supply.
It desperately needs one. Angiogenesis is the process of forming new blood vessels from existing ones. Cancer cells become competent at this. They learn to send out chemical signals, growth factors, telling the host's nearby blood vessels to sprout new branches and grow towards the tumor.
What kind of signals?
The main player is vascular endothelial growth factor, or VEGF. Tumors often pump out huge amounts of VEGF. This essentially hijacks the body's normal vessel-building machinery, creating a dedicated supply line for the tumor. Once it gets vascularized, it can really take off, growing rapidly and becoming a clinically significant mass.
Okay, fed and growing. But to cause widespread disease, it has to leave home. Invasion and dissemination. How does a cell physically break out and travel?
It's a multi-step process, like a prison break. First, just the sheer pressure of all those dividing cells can physically push them outwards into surrounding tissue. Second, they become chemical saboteurs. They start secreting enzymes, things like collagenases and matrix metalloproteinases, MMPs.
What do those do?
They dissolve the surrounding structures, the extracellular matrix, which is like the scaffolding holding tissues together, and the basement membrane, the thin layer separating epithelial cells from the deeper tissues. They literally chew their way through the barriers.
And third, they change their own nature.
Yeah, this is fascinating. They undergo a process called Epithelial-Mesenchymal transition, or EMT. Normal epithelial cells are usually stuck together, quite stationary. In EMT, they change their shape and behavior. They loosen their connections to neighbors, often by messing with surface molecules called integrins, and become more mobile, more like migratory cells you see during embryonic development. They basically switch from being like bricks in a wall to being like little explorers.
And that lets them get into the bloodstream or lymphatic system.
Precisely. Once they've broken through the basement membrane, they can invade blood vessels or lymph channels and get swept away as circulating tumor cells, or CTCs.
But just getting into circulation isn't the end of the story, is it? Most of those CTCs probably die. They have to find somewhere to land and grow again. That brings us to the seed and soil idea.
Yes, a really insightful hypothesis from Stephen Paget over a century ago. He noticed that cancers didn't just spread randomly. Certain cancers tended to metastasize to specific organs. His idea was that successful metastasis needs compatibility between the cancer cell, the seed, and the environment of the distant organ, the soil.
So the destination matters as much as the journey.
Absolutely. Most CTCs are probably destroyed in the bloodstream. It's a hostile environment. To form a metastasis, a surviving cell needs to lodge in a suitable capillary bed, cross the vessel wall again, and find the right molecular signals and supportive cell types in that new tissue, the right soil to start growing. Some research even suggests the primary tumor can send out signals ahead of time to prepare these pre-metastatic niches.
Okay, one last big hurdle.
Hmm.
If these cancer cells are so mutated and abnormal, shouldn't the immune system recognize them as foreign and just wipe them out? Why doesn't that always happen? That's the hallmark of evading detection and elimination, right? Immune surveillance failure.
That's the core question. Paul Ehrlich proposed the idea of immunosurveillance back in 1909, that our immune system is constantly patrolling, looking for and eliminating newly arising cancer cells. And it's almost certainly true. We probably fight off millions of potential cancers without ever knowing it.
So the ones that make it through are the escape artists.
Exactly. The clinically detectable tumors are the ones that have figured out how to evade or actively suppress the immune response. They have a whole bag of tricks.
Like what?
Well, they can downregulate the molecules on their surface that T cells normally recognize, sort of hiding in plain sight. Or, and this is really key for modern therapies, they can exploit the immune system's own off switches, the checkpoints. Yeah, these are mechanisms that normally prevent the immune system from going overboard and causing autoimmune disease. T cells have receptors like PD-1 or CTLA-4 that, when activated, tell the T cell to calm down. Many tumors learn to express the ligands for these receptors, like PD-L1. When the tumor cell displays PD-L1, it engages PD-1 on the T cell and basically tells it, nope, nothing to see here, move along. It puts the brakes on the T cell attack.
And that's what immunotherapy targets.
Yeah.
Releasing those brakes.
Precisely. That's the revolution. T-cell checkpoint inhibitors, drugs like ipilimumab, which blocks CTLA-4, or pembrolizumab, which blocks PD-1, they essentially stop the tumor from using those off switches. They take the brakes off the T-cells, allowing them to recognize and kill the cancer cells much more effectively. It's led to amazing, durable responses in diseases like metastatic melanoma or certain lung cancers that were almost untreatable before.
Incredible. Before we shift gears to causes, let's just quickly touch on the math of tumor growth. You mentioned it's often modeled exponentially, like $2. Yeah. Can you put that into perspective? What does that actually mean for the patient?
Yeah, the basic math is, well, pretty sobering. If you start with one cancer cell and assume it divides without loss, it takes roughly 30 doublings, that's $2, to reach about 1 billion cells.
And 1 billion cells is roughly?
That's about the size of a 1-centimeter tumor, which is typically the lower limit of what we can detect clinically, maybe on a scan or by feel. Now, here's the really critical part. From that point, from that 1-centimeter detectable tumor, it takes maybe only 10 to 15 more doublings to reach a tumor burden that's often fatal, perhaps around $3 times 1013 cells.
Wow. So biologically speaking, once we can actually find the cancer, a large part of its growth history has already happened, and the remaining time in terms of cell generations can be relatively short.
It really underscores the urgency, yes. But we absolutely have to add a big caveat here. That simple exponential model is, well, too simple. In reality, many tumors lose a lot of cells. Think about squamous cancer shedding cells from the surface. Maybe up to 99% of the cells produced are lost. That dramatically changes the net growth rate.
So it's not just pure doubling.
No. And also, growth tends to slow down as tumors get bigger. It's better described by what's called Compertzian growth. Think of it like an S-curve. Growth is fast and almost exponential when the tumor is small, but then it slows down as the tumor mass increases.
Why does it slow down?
Probably because the tumor starts running into logistical problems. It outgrows its blood supply. Cells in the middle become hypoxic, nutrients get scarce, waste products build up. It gets harder to sustain that rapid doubling. Understanding this Compertzian curve is actually really important when we think about how therapies might work. They might be more effective against the rapidly dividing cells in a smaller tumor than the slower growing cells in a large established one.
Okay, that covers the how at the cellular level. Now let's look at the why, what actually starts this whole cascade. It seems to boil down to that classic interplay, nature versus nurture, inheritance versus environment.
Exactly. Both are undeniably important, but the balance between them really depends on the specific type of cancer we're talking about. the contribution varies hugely.
Can you give us some examples to illustrate that?
Yeah. Sure. Let's take two common cancers at opposite ends of the spectrum, maybe lung cancer and certain breast or ovarian cancers.
Okay, lung cancer.
For lung cancer, particularly non-small cell lung cancer, the environment is overwhelmingly dominant. While it might be some genetic susceptibility factors, the impact of smoking is just colossal. It's estimated to account for something like 80% of cases. It's a massive environmental hit.
Even though not everyone who smokes gets lung cancer.
Right, which suggests some genetic modulation of risk, but the primary driver is clearly environmental. Now, contrast that with, say, hereditary breast and ovarian cancer syndrome.
Linked to BRCA genes.
Exactly. If a woman inherits a faulty BRCA1 gene, her lifetime risk of developing breast cancer can shoot up to, well, figures vary, but maybe 60% to 90%. And for ovarian cancer, it's also dramatically elevated. In this case, the inherited genetic factor nature is incredibly powerful, highly penetrant, as we say.
So, knowing the cause, whether it's primarily genetic or environmental, directly influences how we approach prevention, right?
Absolutely. If it's a strong inherited predisposition, the strategies often become very specific, sometimes quite radical, involving intense surveillance or even prophylactic surgery.
Let's talk through a few of those inherited syndromes,
Yeah.
maybe pulling from table 12.1 in the text. What about FAP?
Right, familial adenomatous polyposis, or FAP. This is caused by inheriting a faulty APC gene, usually in an autosomal dominant pattern, meaning you only need one bad copy. APC is a crucial tumor suppressor. Without it working properly, the cells lining the colon just start growing uncontrollably, forming hundreds, sometimes thousands, of polyps.
And the risk of one of those turning cancerous is
High. It's virtually 100% if left untreated. Because of that near certainty, the standard recommendation for people with FAP is often prophylactic panproctocolectomy, removing the entire colon and rectum, usually relatively early in life, combined with regular endoscopic surveillance of the upper GI tract. It's drastic, but life-saving.
Okay, how about Lynch syndrome? That's different, isn't it? Also colorectal cancer risk, but not the thousands of polyps.
Correct. Lynch syndrome, also called HNPCC hereditary non-polyposis colorectal cancer, is caused by inherited defects in DNA mismatch repair genes like MLH1 or MSH2. Their job is basically to proofread the DNA after replication and fix any typos.
So if the proofreaders are faulty,
The mutation rate across the entire genome skyrockets. This microsatellite instability leads to a very high risk of developing cancer, not just colorectal, but also endometrial, ovarian, stomach, and others. Because the cancers can arise in different places and don't have that massive polyp carpet like FAP, the management is more focused on intensive surveillance, frequent colonoscopies starting young, screening for endometrial cancer, mammography, things like that, to catch tumors early.
it would be retinoblastoma. That's a classic example.
Yes. Caused by mutations in the RB gene, another key tumor suppressor, children inheriting one faulty copy are at very high risk of developing this eye tumor. Management involves careful surveillance of the eyes, especially the unaffected one if the first is involved, and genetic counseling for the family.
One more said the MAN syndromes.
Right. The multiple endocrine neoplasia syndromes, MN1 involves the menin gene, while MN2A and 2B involve the RET proto-oncogene. These lead to tumors in various endocrine glands: parathyroid, pituitary, pancreas for MN1, thyroid, adrenal medulla, parathyroid for MN2. Because some of these, like the medullary thyroid cancer and MN2, can be very aggressive and appear in childhood, again, prophylactic surgery like removing the thyroid gland in young children with RET mutations, MEN2A, 2B, is often recommended, alongside screening for hormone levels like calcitonin or catecholamines.
Okay, so for these high-penetrance genetic syndromes, it's often about aggressive screening or even removing its target organ. Now, let's flip back to the nurture side, the environmental factors from table 12.2. What are the big preventable risks there?
Well, the giants are still tobacco and alcohol. Tobacco is linked to so many cancers: lung, head and neck, bladder, pancreas, kidney, the list goes on. Alcohol increases risk for head and neck, esophageal, liver, and breast cancer, often synergistically with smoking.
And the prevention strategies.
They have to be largely societal and policy-based, don't they? Things like punitive taxes on tobacco and alcohol, comprehensive smoking bans in public places, clear health warnings, support for cessation programs. Individual avoidance is key, but public health measures are critical for population-level impact.
What about infections?
That's another huge area where prevention works incredibly well. Human papillomavirus, HPV, is a major cause of cervical cancer, obviously, but also increasingly recognized in penile, anal, and oropharyngeal head and neck cancers. The strategy here is vaccination. The HPV vaccine is a game changer, potentially preventing millions of cancers globally. Avoiding unprotected sex also reduces risk.
Hepatitis.
Hepatitis B virus, HBV, and also hepatitis C are major drivers of hepatocellular carcinoma, primary liver cancer. Again, vaccination against HBV is a cornerstone of prevention, especially universal childhood vaccination programs. Screening blood products and promoting safe injection practices are also vital.
Then there are the chemical exposures, often occupational.
Yes, things like asbestos, a known cause of mesothelioma in lung cancer. Vinyl chloride, used in plastics production, linked to a rare liver cancer called angiosarcoma. Aniline dyes, used historically in textile and rubber industries, linked to bladder cancer. Prevention here relies on strict workplace safety regulations, substituting safer materials where possible, proper handling and disposal, and monitoring workers' health.
And finally, a factor that's becoming increasingly important globally.
Obesity and lack of physical exercise. This lifestyle factor is clearly linked to an increased risk of a whole raft of cancers: postmenopausal breast, endometrium, kidney, colon, esophagus, pancreas, gallbladder. It's a major public health challenge. The prevention message is straightforward, if not always easy to implement. Maintain a healthy body weight throughout life and engage in regular physical activity.
So we've covered how cancer starts and what causes it. Now let's look at how we manage it. And you made a point earlier. We need to move beyond just thinking about diagnosis and active treatment. That old view is too narrow, almost fatalistic.
Absolutely. It completely ignores the massive potential of prevention, and crucially, it often overlooks what happens after active treatment, the long process of rehabilitation and dealing with long-term effects, or the transition to palliative care. Modern cancer management needs a much broader, more holistic perspective.
Find 12.3 in the text illustrates this well, using two axes. Can you walk us through that?
Yeah, it's a helpful way to conceptualize it. The first axis is the axis of scale. This recognizes that cancer management happens at all levels, from the individual making a choice like quitting smoking or agreeing to screening, right up to the level of national healthcare policy or even global initiatives like WHO recommendations for cancer control in developing countries.
So individual actions and societal structures are both part of management.
Exactly. And the second axis is the axis of development. This follows the typical journey or timeline of cancer control. It starts way before the disease even exists, with prevention. Then it moves through screening for early detection in asymptomatic people, then diagnosis once suspicion arises, followed by staging to determine the extent.
Then comes the active treatment phase.
Right. Then follow-up to monitor for recurrence, rehabilitation to help patients regain function and quality of life after treatment, and finally, if cure isn't possible or treatment fails, palliation to manage symptoms and support the patient and family. It's a whole continuum.
Let's zoom in on the early parts of that continuum. Prevention seems straightforward. If difficult, eat well, exercise, avoid known carcinogens like smoke, and maybe identify those premalignant conditions early, like keeping a close eye on Barrett's esophagus.
That's the core of primary and secondary prevention, yes. But screening is where things get much more complex and, frankly, quite controversial sometimes.
So let's define it clearly first. What exactly is screening?
Screening is the specific process of looking for evidence of a disease like cancer in people who have no symptoms whatsoever. The whole point, the explicit goal, is to improve outcomes, usually survival, by diagnosing the cancer at an earlier, potentially more curable stage than if we waited for symptoms to appear.
It sounds logical. Find it early, treat it early, better outcome.
That's the underlying assumption. But for a screening program to be justified, ethically and scientifically, it has to meet a pretty strict set of criteria, often summarized as the Wilson-Jungner criteria. These are really important for anyone involved in public health or oncology to understand.
Okay, let's break those down. What are the key requirements? They cover the disease, the test, and the program itself.
Right. First, regarding the disease, it needs to be a significant health problem. There must be a recognizable early or latent stage. And critically, there must be an effective treatment available and evidence that treating the disease at that early screen-detected stage actually leads to a better outcome than treating it later when symptoms develop. Not all early cancers necessarily benefit from early treatment.
What about the test used for screening?
The test itself needs to be good. It should be reasonably sensitive, meaning it picks up most cases of the disease, minimizing false negatives. It needs to be specific, meaning it correctly identifies those without the disease, minimizing false positives. It has to be safe, relatively inexpensive, and, crucially, acceptable to the population you're targeting. If people won't do the test, the program fails.
And finally, the requirements for the program as a whole.
This is often where the challenges lie. You need adequate healthcare facilities and resources to handle the diagnostic workup for everyone who screens positive and to provide treatment for those confirmed to have the disease. And the absolute bottom line, the overall benefits of the screening program, usually measured in terms of reduced mortality from that specific cancer in the population, must demonstrably outweigh the potential harm.
Harms. What kind of harms can screening cause?
Oh, several kinds. There's the anxiety and stress of a positive test, even if it turns out to be false. There's the risk and discomfort of follow-up diagnostic procedures like biopsies. There's the cost to the healthcare system. And perhaps the most complex harm is overdiagnosis, detecting cancers that are so slow-growing they would never have caused symptoms or death in the person's lifetime. Treating these pseudo-diseases provides no benefit but exposes the person to the risks of treatment.
This brings us to a really critical point you mentioned earlier, why simply showing that people whose cancer was found by screening live longer after diagnosis than people whose cancer was found because of symptoms is not good enough proof that screening works. This is about bias, isn't it?
Exactly. This is a major learning point, especially for revision. There are several powerful biases inherent in screening that can create the illusion of benefit even when none exists. The most famous is lead time bias.
Okay, explain lead time bias. Let's use figure 12.4 as example. Tumor A.
Right. Imagine a tumor, tumor A, starts growing. Without screening, the patient develops symptoms at, say, year 5 and dies at year 8. Their survival after diagnosis is 3 years. Now, imagine screening detects that same tumor earlier at year 3. The patient still dies at year 8 because the treatment didn't change the outcome. But now, their measured survival after diagnosis is 5 years, from year 3 to year 8.
So the survival time looks longer just because you started the clock earlier.
Precisely. The lead time is those extra 2 years gained purely by the earlier diagnosis, not by better treatment. Screening always introduces lead time, so just comparing survival from diagnosis between screened and unscreened groups is fundamentally misleading.
Wow, okay. That's a big one. What other biases mess up the picture?
Another major one is selection bias, sometimes called healthy volunteer bias. Think about who typically participates in screening programs. It's often people who are generally more health conscious, perhaps better educated, maybe have healthier lifestyles overall compared to those who don't participate.
Some might live longer anyway, regardless of the screening test.
Exactly. The group that chooses to be screened might inherently have a better prognosis than the group that doesn't, just because of who they are. So comparing outcomes between these two self-selected groups isn't a fair comparison of the screening test itself.
Makes sense. And the third big one is length bias.
Yes, length bias. This relates to the type of cancers screening tends to find. Think about two tumors. Tumor A grows slowly over many years. Tumor B grows very rapidly and aggressively. A screening test done, say, every 2 years is much more likely to detect the slow-growing tumor A during its long, detectable preclinical phase.
Whereas the fast one might pop up and cause symptoms between screens.
Right. The aggressive tumor B might arise and become symptomatic or even fatal in the interval between screening tests. So the cancers detected by screening tend to be enriched for the slower-growing, inherently less aggressive types, like tumor A, while missing more of the fast-growing ones, tumor B. This makes the cancers found by screening look like they have a better prognosis, partly because they are biologically less aggressive on average.
So, lead time makes survival look longer, selection bias means you're screening healthier people, and length bias means you're finding the slower cancers.
It sounds like proving screening actually saves lives is really tough.
It is tough, and it requires very rigorous methods. Because of these biases, the only scientifically valid way to prove that a screening program works, that it genuinely reduces deaths from the cancer, is through large-scale randomized controlled trials, RCTs.
How do those work?
You take a large population and randomly assign people either to be offered the screening test or to receive usual care, no screening offer. Then you follow both groups for many years and compare the number of deaths from that specific cancer in each group. If the group offered screening has a statistically significant lower mortality rate from that cancer, then you have strong evidence that the screening program is beneficial.
And have any screening programs shown that kind of benefit in RCTs? Yes, absolutely. High-quality RCTs have demonstrated mortality reductions for mammography, screening for breast cancer, screening for colorectal cancer, using tests like fecal occult blood testing or sigmoidoscopy colonoscopy, and in some specific high-risk populations, low-dose CT screening for lung cancer. But it's crucial that this high-level evidence exists before implementing widespread population screening.
Okay, so let's say screening, or symptoms, leads to a suspicion of cancer. The next step is nailing down the diagnosis, and that means getting tissue right.
Absolutely essential. You need a pathologist to look at cells or tissue under a microscope. That could be cytology, looking at shed cells, or cells from a fine needle aspirate, or histology, looking at the structure of a tissue biopsy or a resection specimen. That pathological confirmation is the cornerstone.
And part of that diagnosis is grading the tumor. What does that tell us?
Grading assesses how abnormal the cancer cells look compared to the normal cells they originated from. It reflects the degree of differentiation. Most common epithelial cancers are graded, usually G1, G2, or G3.
G1 being.
G1 is well differentiated. The cancer cells still look quite a lot like the normal tissue cells. They tend to be slower growing and have a better prognosis. G3 is poorly differentiated or undifferentiated. The cells look very abnormal, disorganized, often growing rapidly, and associated with a worse prognosis. G2 is somewhere in between.
Is there any major exception to that G1, G3 system?
The big one is prostate cancer. It uses the Gleason grading system. This is unique because it's based on the architectural patterns of the glands, not just how individual cells look. And crucially, the pathologist identifies the two most common patterns present in the sample, assigns each a grade from 1 to 5, though 1 and 2 are rarely used now, so it's effectively 3 to 5, and then adds them together.
So you get a Gleason score, like 3 plus 4, 7, or 4 plus 5, 9.
Exactly. A Gleason score of 6, 3 plus 3, is generally considered lower risk, while scores of 8, 9, like 4 plus 5 or 5 plus 4 or 10, 5 plus 5, indicate more aggressive disease with a poorer prognosis. It's a powerful predictor.
Beyond grading based on appearance, you mentioned earlier that the future is molecular classification.
It's not just the future, it's increasingly the present. We're moving rapidly towards characterizing tumors based on their specific genetic mutations or molecular profiles. This is the heart of personalized or precision medicine.
Give us an example again.
Well, the BRAF V600E mutation in melanoma is a prime example. If a patient's melanoma has that specific mutation, they're likely to respond dramatically to drugs that specifically target that mutated BRAF protein, like vemurafenib. But if they don't have the mutation, the drug won't work at all. So molecular testing is now standard practice to guide treatment choices in melanoma, lung cancer, EGFR mutations, ALK rearrangements, breast cancer, HER2 status, estrogen progesterone receptors, colorectal cancer, RAS-R mutations, and many others. We're treating the specific vulnerability, not just the location.
Okay, so we have the diagnosis, the grade, maybe some molecular features. Now we need to know how far it's spread. It's staging. Why is staging so critical?
Staging is arguably the most important factor in determining prognosis and guiding the overall treatment strategy. It maps out the anatomical extent of the cancer. Is it confined to the organ of origin? Has it spread to nearby lymph nodes? Has it metastasized to distant parts of the body?
And the answer dictates the approach.
Fundamentally, if the cancer is localized, stage 1 or 2 generally, the primary goal is usually cure, often using local treatments like surgery and/or radiation. If it has spread regionally to lymph nodes, stage 3, we might still aim for cure, but often need a combination of local and systemic treatments like chemotherapy. If it has spread distantly, stage 4, metastatic disease, cure is much less likely for most solid tumors, and the focus often shifts towards systemic therapy to control the disease and manage symptoms.
You also mentioned earlier that staging has changed dramatically because of technology.
Hugely. Modern staging relies heavily on high-resolution imaging like CT scans, MRI, and increasingly PET scans, which show metabolic activity. These tools can detect small metastases or lymph node involvement that would have been completely invisible 20 or 30 years ago.
So someone staged today might seem to have worse disease than someone staged in, say, 1985.
Exactly. It's called stage migration. Because we're better at finding small amounts of spread, patients get upstaged compared to historical cohorts. It means you can't directly compare survival statistics for, say, stage 3 colon cancer from 1985 with stage 3 colon cancer diagnosed today. The definition of the stage has effectively changed due to better detection. It's something you always have to keep in mind when looking at older data.
The universal language for staging is the TNM system. Can you break down what T, N, and M stand for?
Sure. It's maintained by the UICC, the International Union Against Cancer, and AJCC in the US. T stands for the primary tumor. It describes the size and their extent of invasion of the main tumor mass. The definitions vary for each cancer site, but generally higher T numbers, T1, T2, T3, T4, indicate larger size or deeper invasion.
Let's use the colorectal cancer example from Table 12.3. What's a T1 versus a T4?
Okay, for colorectal cancer, a T1 tumor has invaded through the first layer, mucosa, into the submucosa underneath. A T4A tumor has grown all the way through the bowel wall and penetrated the visceral peritoneum, the outer lining. T4B means it's directly invading into adjacent organs or structures, so big difference in local extent.
Okay, what about them?
N stands for regional lymph nodes. It indicates whether the cancer has spread to the lymph nodes near the primary tumor and how many or which specific nodes are involved. N0 means no nodal involvement. N1 and N2, and sometimes N3, indicate increasing degrees of spread to regional nodes. For example, N1 might be 1 through quasitive nodes, N2 might be 4 or more. Again, the specifics vary by cancer type.
And
M stands for distant metastasis. This is the simplest category. N0 means no evidence of spread to distant organs like liver, lungs, bones, brain. M1 means distant metastases are present. Sometimes M1 is further subdivided, M1A, M1B, M1C, to indicate the site or extent of metastatic disease, which can also affect prognosis and treatment. For instance, M1C in colorectal cancer indicates spread to the peritoneal surface.
so you put T, N, and M together to get the overall stage, usually grouped into stages 1, 2, 3, and 4.
Correct. For example, a small tumor that hasn't spread to nodes or distant sites might be stage I, example T1, N0, M0. A larger tumor with node involvement but no distant spread might be stage 3, example T3, N1, M0. Any tumor with distant metastases is automatically stage 4, any T, any N, M1. This overall stage provides the best estimate of prognosis and is the primary guide for treatment planning.
And you mentioned a potential future addition or refinement to staging
Yeah.
using blood tests.
Yes, this is a really exciting area.
Yeah.
Using circulating tumor DNA, ctDNA. This involves looking for tiny fragments of DNA shed from the tumor into the patient's bloodstream. The idea is that even after a tumor is surgically removed, making the patient technically TLO N0, M0 on scans, if ctDNA is still detectable in their blood, it strongly suggests there's still microscopic disease left behind, somewhere minimal residual disease, MRD.
And that predicts recurrence.
Early data suggests it's a very powerful predictor of relapse. Patients who are ctDNA positive after surgery seem to have a much higher risk of the cancer coming back compared to those who are ctDNA negative. This could revolutionize how we decide who needs adjuvant therapy after surgery. We could potentially target treatment only to those MRD-positive patients, sparing the others unnecessary toxicity. It's a major focus of research right now.
Okay, with all this complexity, imaging, pathology, molecular tests, staging, treatment options, it seems impossible for one doctor to manage everything.
Yeah.
This is where the multidisciplinary team, MDT, comes in, right?
Absolutely indispensable in modern cancer care. You really need input from multiple specialists, and it's not just multidisciplinary, it should be multi-professional.
Right.
Meaning it includes not just different types of doctors, surgeons, medical oncologists, radiation oncologists, radiologists, pathologists, but also crucial non-physician roles like clinical nurse specialists, pharmacists, dietitians, physiotherapists, palliative care specialists, social workers, psychologists. Everyone brings a different perspective.
What's the core function of the MDT meeting? What are they trying to achieve?
Essentially, they need to collectively answer 3 fundamental questions for each patient. 1, what is the precise diagnosis, stage, grade, and relevant molecular characteristics of this cancer? 2, what is the realistic goal of treatment for this specific patient? Is it cure, prolonging life significantly, or primarily palliation of symptoms? 3, given the diagnosis and the goal, what are the best available treatment options or combinations to achieve that goal, considering efficacy, potential side effects, and the patient's overall situation?
Sounds ideal in theory. Open discussion, shared expertise. But the textbook, Table 12.4, mentions potential downsides or challenges with MDTs in practice.
Yeah, they're not perfect systems. The pros are clear. Better decision-making through diverse input, transparency, consistency of care, quality assurance, education for trainees. But there are definite cons.
Such as?
Well, sometimes the discussion can be dominated by more senior or assertive personalities, and quieter voices with valuable insights might not be heard. There's a risk of rubber stamping, just applying standard guidelines without really considering the individual nuances of the patient. They are incredibly time-consuming and resource-intensive, pulling many highly paid professionals away from direct patient care for hours each week.
And a potential for diffusion of responsibility.
That's another concern. Sometimes clinicians might feel less personally responsible for a decision if it's seen as a committee recommendation, potentially reducing individual critical thinking or advocacy for a specific patient's needs if they differ from the group consensus.
And ultimately, the MDT makes recommendations, but the final conversation and decision happen between the clinician and the patient.
That is absolutely paramount. The MDT provides expert consensus on the options and the likely outcomes, but the treating clinician then needs to sit down with the patient, discuss those recommendations, and critically assess them in the context of that individual. How fit are they? What other medical problems do they have? Comorbidities? What are their values and priorities? Do they value length of life above all else? Or is quality of life and avoiding severe side effects more important to them? The MDT informs, but the final management plan must be a shared decision tailored to the unique person sitting in front of you.
Okay, let's move into the treatments themselves. For most solid tumors, surgery is still the cornerstone, isn't it? Often the best, maybe the only, shot at a cure.
For localized solid tumors, yes, surgical resection with the aim of complete removal remains the most effective curative modality in most cases. But the surgeon's role in cancer care is actually much broader than just cutting out the primary tumor.
What are those other roles?
Well, first, diagnosis and staging. Sometimes the diagnosis is only confirmed after removing the entire thing, like an orchidectomy removal of the testicle for a suspected testicular cancer. Biopsies are obviously surgical procedures too, and increasingly, minimally invasive surgery like laparoscopy is used specifically for staging, for example, to look for tiny peritoneal metastases in stomach or pancreatic cancer that weren't visible on scans, which can completely change the treatment plan.
Okay, diagnosis, staging. Then the main event, removal of the primary disease.
Right. This is the classic radical surgery concept, removing the tumor itself, a margin of surrounding healthy tissue to ensure no microscopic bits are left behind, aiming for clear margins. And often the nearby lymph nodes that drain that area, lymphadenectomy, to check for spread and achieve regional control.
We used to hear about ultra-radical surgeries.
Yeah.
Have those proven beneficial?
That's a key historical lesson, particularly from breast cancer trials decades ago. It turned out that performing massive mutilating operations, like the original Halsted radical mastectomy, didn't actually improve survival compared to less extensive surgery, like modified radical mastectomy or lumpectomy plus radiation, when it came to preventing distant metastatic disease. The conclusion was that meticulous local control is vital. But once cancer cells have escaped systemically, more aggressive local surgery doesn't really help. Good technique is crucial, but ultra-radical isn't necessarily better for survival.
Can surgery ever be curative if the cancer is already spread? Removal of metastatic disease?
Yes, in certain specific situations, surgery for metastases can be curative, or at least lead to very long-term survival. This is sometimes called metastasectomy. The success really depends on the type of primary cancer, where the metastases are and how many there are. Oligometastatic disease, meaning only a few metastases.
What's the best example?
The classic success story is resection of liver metastases from colorectal cancer. If a patient has colorectal cancer that has spread only to the liver and the metastases are surgically removable, complete resection can lead to 5-year survival rates of 30–50% or even higher in selected patients, which is remarkable for stage 4 disease.
Are there other examples?
Yes, resection of isolated pulmonary lung metastases can also be curative in some cases, particularly for certain tumor types like sarcoma, renal cell carcinoma, or sometimes colorectal cancer, again, if the disease is truly limited. We also use other techniques besides cutting them out, like local ablation using heat, radiofrequency ablation, RFA, or cold cryotherapy to destroy metastases, often guided by imaging.
And finally, even if cure isn't possible, surgery still has a role in palliation.
A huge role. Palliative surgery is aimed at relieving symptoms and improving quality of life, not curing the cancer. For example, if a large tumor is causing pain, bleeding, or obstruction, like blocking the bowel, surgery to remove or bypass it can make a massive difference to the patient's comfort, even if they have widespread metastatic disease elsewhere. Debulking a large symptomatic primary tumor can sometimes make subsequent chemotherapy more effective too. #B, non-surgical treatment principles.
Okay, let's shift to the non-surgical approaches, medical oncology, clinical oncology, radiation oncology. These fields are evolving incredibly fast, driven by that molecular understanding we talked about. What are the main purposes or settings where these treatments are used?
We can think about them in roughly 4 main categories, similar to how we use surgery. First, as the curative primary treatment. For some cancers, non-surgical therapy alone offers a very high chance of cure. Think of chemotherapy for leukemias and lymphomas, or definitive radiotherapy, sometimes with chemotherapy, for early-stage head and neck cancers like laryngeal cancer, or for squamous cell cancer of the anus. Surgery might not be needed at all, or only for salvage if the non-surgical treatment fails.
Okay, curative primary. Then there are the adjuvant therapies, working alongside surgery.
Right. We have neoadjuvant therapy, which is given before the main local treatment, usually surgery. The aim is typically to shrink the tumor, making it easier to remove completely, potentially allowing for less extensive surgery, like breast conservation instead of mastectomy, or to treat microscopic metastatic disease early on. A classic example is chemoradiotherapy before surgery for rectal cancer to downstage the tumor and reduce recurrence risk.
And adjuvant therapy.
That's given after the primary curative treatment, usually surgery. The goal here is to eradicate any tiny, undetectable cancer cells, micrometastases, that might have already escaped, thereby increasing the overall chance of cure. Common examples include adjuvant chemotherapy after surgery for colon or breast cancer, or adjuvant radiotherapy after prostatectomy or lumpectomy.
And the fourth category, when cure isn't the primary goal.
That's treatment for advanced or metastatic disease, which we can broadly categorize as life-prolonging or palliative. It's important to try and distinguish these. Palliative treatment focuses purely on relieving symptoms like pain or nausea. Life-prolonging therapy, while also palliative intent, aims to significantly extend survival, sometimes by months or even years, while maintaining a reasonable quality of life. Think of targeted therapies like olaparib for BRCA-mutated ovarian cancer. It can control the disease for a long time, turning it into more of a chronic condition.
Let's revisit the adjuvant dilemma you mentioned earlier, figures 12.5 and 12.6. This really highlights a major challenge in using these post-surgical treatments.
It really does. It's a crucial concept for understanding the limitations and rationale. When we give adjuvant therapy, we're treating patients who have had their visible cancer removed, but we suspect some might have invisible residual disease. Let's say, hypothetically, that surgery alone cures 70% of patients in a particular group.
So 70 out of 100 are already cured.
Right. Now, we give adjuvant chemotherapy to all 100 patients. Those 70 patients who are already cured get absolutely no benefit from the chemo, but they are exposed to all its potential side effects and toxicity.
Okay, what about the other 30 who weren't cured by surgery?
Of those 30 who actually have residual disease, maybe the chemotherapy is only effective in a fraction of them. Let's say it cures an extra 10 patients, so maybe it works in about a third of those with residual disease.
So to cure those extra 10 people, you had to treat 100, meaning 90 people received toxic treatment unnecessarily. 70 already cured, 20 with residual disease.
Exactly. That's the dilemma. That 10% absolute improvement in cure rate is hugely significant. It's 10 lives saved. But it comes at the cost of over-treating the vast majority. This is why there's such a massive drive to develop better ways like ctDNA testing to identify which patients actually have that minimal residual disease and are therefore most likely to benefit from adjuvant therapy so we can spare the others. Hashtag Radiotherapy, RT.
All right, let's focus on one of the main non-surgical modalities, radiotherapy, or RT. About half of all cancer patients end up receiving RT at some point. How does it actually work? How does radiation kill cancer cells?
The fundamental mechanism is damage to DNA. Ionizing radiation, high-energy X-rays or particles deposits energy in the cells it passes through, and this energy causes breaks in the DNA strands. Double-strand breaks are particularly lethal because they're very difficult for the cell to repair accurately. Cells are generally most sensitive to this damage when they're actively dividing in the M and G2 phases of the cell cycle.
Is the damage direct, the radiation hitting the DNA?
Some of it is direct damage, yes. But the majority of the biological effect, especially with the types of radiation typically used, photons like X-rays, is actually indirect. The radiation interacts with water molecules within the cell, and cells are mostly water, creating highly reactive molecules called oxygen-free radicals.
And these radicals then attack the DNA.
Exactly. These free radicals are short-lived but very damaging, and they cause a lot of the DNA breaks. This indirect mechanism is really important because it explains the oxygen problem in radiotherapy.
What's the oxygen problem?
Free radical formation requires oxygen. Cells that are starved of oxygen-hypoxic cells, often found in the center of larger tumors that have outgrown their blood supply, are significantly more resistant to radiation damage, maybe 2 to 3 times more resistant because fewer free radicals are generated.
So improving oxygen levels in the tumor helps RT work better.
Yes. That's why things like correcting anemia before starting RT can be important. Better oxygen carrying capacity in the blood can help oxygenate the tumor better. Researchers have also tried things like hyperbaric oxygen or drugs that mimic oxygen hypoxic cell sensitizers, though with mixed success. Overcoming hypoxia remains a major challenge.
Radiotherapy is mostly a localized treatment targeting a specific area. But the planning seems incredibly precise now. How is that done?
Modern radiotherapy planning is extremely sophisticated, a real blend of physics, computing, and anatomy. The dose prescribed varies hugely depending on the goal. For trying to eradicate a visible tumor, you might need a high dose, maybe 60-70 gray or more, delivered over several weeks. For treating microscopic residual disease after surgery, adjuvant RT, maybe 50 G is enough. For palliation of symptoms like bone pain, a short course to 20-30 G might suffice.
And how do they aim it so precisely? Figure 12.7?
It requires detailed 3D imaging. Usually, a dedicated CT scan is done in the treatment position, often fused with MRI for better soft tissue detail, and sometimes PT scans to identify the most metabolically active hot areas of the tumor. The radiation oncologist then meticulously outlines the target volume, the tumor plus a margin, and also outlines all the nearby critical normal organs that need to be protected. Organs at risk, OARs, like the spinal cord, lungs, heart, salivary glands, etc.
And then computers figure out how to deliver the dose.
Highly complex treatment planning software calculates the optimal arrangement of radiation beams, their angles, shapes, and intensities, to deliver the prescribed dose to the target while minimizing the dose to the surrounding OARs. This has led to advanced techniques like IMRT, intensity-modulated radiation therapy, which uses hundreds of small beamlets with varying intensities to sculpt the dose very precisely around complex shapes. IGRT, image-guided radiation therapy, uses imaging right before or during treatment delivery to verify patient positioning and ensure the beams are hitting the target accurately every day.
There's also a technique called SAB stereotactic.
Stereotactic ablative radiotherapy, sometimes called SBRT, stereotactic body radiation therapy. This is a major advance, using highly focused, very high doses of radiation delivered in just a few treatment sessions, often 1 to 5. Because the dose per fraction is so high, it can actually ablate or destroy small tumors with an effectiveness approaching surgery in some cases. It's increasingly used for small primary lung cancers in patients unfit for surgery, or for treating isolated metastases in the lung, liver, spine, or brain.
Are there other ways to deliver radiation besides external beams?
Yes. Brachytherapy involves placing radioactive sources directly inside or very close to the tumor. Examples include seeds implanted into the prostate or sources placed temporarily in the cervix or bronchus. This delivers a very high dose locally with rapid fall-off, sparing surrounding tissues. There's also radionuclide therapy, where a radioactive substance is attached to a molecule that targets cancer cells and is given systemically, like radioactive iodine for thyroid cancer or lutetium PSMA for prostate cancer.
The text mentions a specific challenge with RT research, the time delay problem between acute and late side effects. Why is that such an issue?
It's a fundamental difficulty. Acute side effects like skin redness, fatigue, mucositis happen during or shortly after treatment and usually resolve. Late side effects like fibrosis, scarring, damage to nerves or blood vessels, organ dysfunction, or even secondary cancers induced by the radiation can take months, years, or even decades to develop.
And the acute effects don't predict the late ones.
Not reliably, no.
Yeah.
You can have significant acute toxicity with minimal late effects, or vice versa. This makes it very difficult to assess the true long-term safety of new radiation techniques or schedules quickly. If we change a fractionation schedule today to try and improve cure rates, we might not know the full impact on late toxicity for 10 or 20 years. It forces a degree of caution when innovating in radiotherapy compared to, say, drug development, where toxicity often appears sooner. #D systemic therapies.
All right, let's turn to therapies that travel throughout the body. Systemic therapies. This is where a lot of the personalized medicine action is, finding those druggable targets. Can we review the main classes of drugs used? Table 12.6.
Sure. The oldest class, and still a mainstay for many cancers, is cytotoxic chemotherapy. The basic principle here is selective toxicity. These drugs preferentially kill rapidly dividing cells. Since cancer cells often divide faster than most normal cells, they are hopefully more affected.
But some normal cells also divide rapidly.
Exactly, like cells in the bone marrow, producing blood cells, hair follicles, and the lining of the gut. That's why chemotherapy commonly causes side effects like low blood counts, increasing infection risk, hair loss, nausea, and diarrhea. We typically give chemo in cycles, maybe a treatment day or week, followed by a 2-3 week rest period to allow these normal tissues time to recover before the next dose.
Can you give some examples of chemo drugs and how they work?
There are many classes. Some interfere with cell division machinery, like vincristine, a vinca alkaloid, which messes up microtubule formation needed for mitosis. Others directly damage DNA, like cisplatin, a platinum compound, which causes crosslinks in the DNA, or doxorubicin, an anthracycline, which slips between DNA-base pairs, intercalation, and inhibits enzymes needed for replication. Many others target DNA synthesis pathways.
Okay, beyond classic chemo, what's next? Hormonal treatments.
Yes, these are crucial for cancers that are driven by hormones, primarily certain types of breast cancer, estrogen progesterone sensitive, and most prostate cancers, androgen sensitive. The strategy is to block the hormone's ability to stimulate the cancer cells.
How's that done?
For estrogen-sensitive breast cancer, drugs like tamoxifen act as selective estrogen receptor modulators, SERMs, blocking estrogen from binding to its receptor in breast tissue. Another class, aromatase inhibitors, block the production of estrogen in postmenopausal women. For prostate cancer, the main approach is androgen deprivation therapy. ADT drugs like leuprolide, a GnRH analog, shut down testosterone production by the testes, effectively starving the cancer cells of their primary fuel.
Then we get to the really specific drugs. Targeted treatments. This is personalized medicine in action.
This is exactly it. These drugs are designed, often based on detailed molecular understanding, to hit a very specific target, usually a protein or pathway that is known to be critical for that particular cancer cell's growth or survival. Because they're so specific, they often require testing the patient's tumor for the presence of that specific target beforehand.
We mentioned vimurafenib for BRAF mutated melanoma. Any other examples?
Oh, many now. Osimertinib is a highly effective inhibitor of mutated EGFR, epidermal growth factor receptor, in certain lung cancers. Imatinib was the poster child, targeting the specific BCR-ABL fusion protein that drives chronic myeloid leukemia, CML. There are inhibitors for ALK, ROS1, MET, HR2. The list keeps growing. While some really important targets, like mutations in the ROS proteins, have proven very difficult to drug effectively, undruggable, the progress in finding and hitting specific vulnerabilities has been phenomenal.
And the newest wave, arguably the most exciting in recent years, is immunotherapy.
Definitely. As we discussed with the Hallmarks, this approach aims to harness the patient's own immune system to fight the cancer. The biggest breakthroughs have come from targeting those T-cell checkpoints, the brakes that tumors use to shut down the immune attack.
So the checkpoint inhibitor drugs.
Drugs like ipilimumab, which blocks CTLA-4, and pembrolizumab or nivolumab, which block PD-1 or its ligand PD-L1, have revolutionized the treatment of several cancers, particularly metastatic melanoma, certain lung cancers, kidney cancer, bladder cancer, and others. By releasing these brakes, they allow the patient's T cells to recognize and kill the tumor cells effectively, sometimes leading to very durable, long-lasting responses even in advanced disease.
What about side effects? Are they better tolerated than chemo?
Often, yes, in terms of the typical chemo side effects like nausea and hair loss. However, because immunotherapy works by unleashing the immune system, it can sometimes lead to the immune system attacking normal tissues, causing a unique set of immune-related adverse events, IRAEs. These can affect almost any organ, causing colitis, inflammation of the colon, pneumonitis lungs, hepatitis liver, thyroiditis, hypophysitis, pituitary gland, arthritis, skin rashes. Some of these can be severe or even life-threatening if not recognized and managed promptly, usually with steroids or other immunosuppressants. ###E principles of combined treatment.
So we have surgery, radiation, chemo, hormonal therapy, targeted drugs, immunotherapy. But often, these aren't used alone. Treatments are frequently combined. Why is that? What's the rationale for using combinations? Summary box 12.4.
The core reason for combining treatments, especially systemic therapies like chemotherapy, is very similar to why we use combination antibiotics for serious infections, to overcome or prevent resistance.
Cancer cells become resistant to drugs.
Yes, unfortunately. Within any large population of cancer cells, due to random genetic mutations, there are likely to be a few cells that are already inherently resistant to any single drug, even before that drug is given. If you treat with only that one drug, you'll kill off all the sensitive cells, but those few resistant ones will survive and regrow, leading to relapse.
So hitting them with multiple things at once makes it harder for resistant cells to survive.
Exactly. It's much less likely that a single cell will happen to be resistant to 2 or 3 drugs with different mechanisms of action simultaneously. So combination therapy significantly reduces the chance of resistance emerging.
Are there specific principles for choosing which drugs to combine?
Yes, there are 3 main principles. First, you should ideally combine drugs that are each known to be active against that type of cancer when used alone. Throwing inactive drugs into the mix doesn't usually help.
Second.
Second, you should combine agents that have distinct modes of action. If two drugs kill cells in exactly the same way, you probably won't get much more benefit than just using one of them at a higher dose. But if they work differently, say, one damages DNA and the other blocks cell division, you might achieve synergy, where the combined effect is actually greater than just adding the effects of each drug individually.
And the third principle is about safety.
Critically important. You need to combine agents that have non-overlapping major toxicities. For example, you generally wouldn't want to combine two drugs that are both severely toxic to the bone marrow, myelosuppressive, or two drugs that both carry a high risk of heart damage or kidney damage. You try to choose partners whose side effect profiles are different so the patient can tolerate the combination.
We also combine different modalities, like radiation and chemotherapy. What's the idea there?
That often involves spatial cooperation. Radiation is excellent for controlling disease in a specific defined area, local control. Chemotherapy or other systemic drugs travel throughout the body, treating potential microscopic disease everywhere, systemic control. They complement each other.
Can chemo help radiation work better or vice versa?
Yes, sometimes chemotherapy can act as a radiosensitizer, making cancer cells more susceptible to being killed by radiation when given concurrently. Also, radiation can sometimes reach sanctuary sites where systemic drugs don't penetrate well, like the brain or the testes. A classic example is giving prophylactic cranial irradiation, PCI, along with chemotherapy for small cell lung cancer, because the chemo doesn't cross the blood-brain barrier well, but radiation can treat potential microscopic disease in the brain.
As we near the end of the management spectrum, we need to talk about complications in supportive care. Are there situations in oncology that count as true emergencies, needing immediate action?
Yes, there are a few critical oncological emergencies where prompt recognition and management can be life-saving or function-saving. The top one is probably spinal cord compression.
What are the signs?
Any patient with known cancer who develops new, severe back pain, especially if it's worse when lying down, or any new neurological symptoms in the legs or bladder bowel problems, should be suspected of having cord compression from spinal metastases until proven otherwise. Delay in treatment can lead to permanent paralysis.
How is it treated?
It requires immediate high-dose steroids, like dexamethasone, to reduce swelling, urgent imaging, usually MRI, and then rapid definitive treatment, which might be emergency neurosurgery to decompress the cord or urgent radiotherapy to shrink the tumor pressing on the cord. Ideally, you want to treat it when it's only threatened before major neurological damage occurs.
Okay, cord compression. What else?
Neutropenic sepsis. This is a major risk with many chemotherapy regimens. The chemo wipes out the white blood cells, neutropenia, leaving the patient highly vulnerable to infection. If a neutropenic patient develops a fever or signs of infection, it's a medical emergency.
Why so urgent?
Because without neutrophils to fight it, infection can become overwhelming very quickly. There's an inverse relationship between the time it takes to start broad-spectrum intravenous antibiotics and the patient's chance of survival. Every hour counts. Hospitals have protocols for this door-to-needle time for antibiotics needs to be very short, often less than 60 minutes.
Any others? Maybe related to newer treatments?
Yes. With the rise of immunotherapy, we now see acute, severe immune-related adverse events that can be emergencies. Things like severe colitis causing perforation, pneumonitis causing respiratory failure, or endocrine emergencies like hypophysitis leading to adrenal crisis, or even sudden onset insulin-dependent diabetes, DKA. Recognizing these specific toxicities is crucial.
Are there other urgent situations, maybe not quite full emergencies?
Sure. Things like blood clots, thrombosis, which is very common in cancer patients, symptomatic fluid collections like pleural effusions or ascites, superior vena cava, SVC obstruction, causing facial swelling and breathing difficulty, uncontrolled cancer pain. These all require urgent attention and management, even if they aren't immediately life-threatening in the same way as cord compression or neutropenic sepsis.
You mentioned earlier that the line between active treatment and palliative care is blurring, especially with targeted therapies allowing people to live with cancer for longer.
It really is. For many patients with advanced cancer, particularly those responding well to newer systemic therapies, the disease becomes more like a chronic condition that needs ongoing management rather than an acute terminal illness. The goal shifts from eradication to control, maintaining quality of life for as long as possible. This means palliative care principles shouldn't be seen as something reserved only for the very end of life.
So palliative care should be integrated earlier.
Absolutely. The evidence is quite strong now that early referral to palliative care, sometimes even right from the time of diagnosis of advanced cancer, improves symptom control, quality of life, patient and family satisfaction, and can even prolong survival in some cases, compared to introducing it only when curative options are exhausted.
What does palliative care actually encompass? It's more than just pain relief, right? Cable 12.7.
Much more. It's a holistic approach. Yes, managing physical symptoms like pain, fatigue, which is incredibly common and debilitating, shortness of breath, dyspnea, nausea, constipation is key, but it also addresses psychosocial needs, anxiety, depression, coping mechanisms, practical support, help with finances, transportation, home care, and spiritual or existential concerns, finding meaning, dealing with fear, hopes for the future. It really aims to support the whole person and their family.
And how are symptoms managed?
Using all the tools available, medications are crucial, obviously opioids for pain, antiemetics for nausea, etc. But also interventions like radiotherapy for painful bone metastases, surgery to relieve obstruction, draining fluid collections, effusions, using bisphosphonates for high calcium levels, hypercalcemia, even non-drug approaches like physiotherapy for fatigue. Aerobic exercise is surprisingly helpful, nutritional support for weight loss, counseling, complementary therapies if the patient finds them beneficial.
Finally, we need to distinguish general palliative care, which might go on for years, from the specific phase of end-of-life care.
Yes, that's an important distinction. End-of-life care typically refers to the care provided in the last few months, weeks, or days of life, when the focus shifts definitively away from disease modification towards comfort, dignity, and preparing for death.
What specific issues become prominent then? Summary box 12.5.
The needs often intensify. There might be heightened spiritual or existential distress, profound fear of dying or the unknown, increased need for symptom control as the body weakens. Communication becomes even more critical, discussing goals of care, understanding the patient's wishes about resuscitation or other interventions, ensuring their preferences for place of death, home, hospice, hospital, are known and respected. Supporting the family through the dying process and into bereavement is also a core component. Discussions around the appropriateness of potentially burdensome interventions, or even patient requests regarding euthanasia or physician-assisted suicide, where legally permissible and ethically debated, may arise. The ultimate aim is to help the patient achieve as much as possible what they would consider a good death. #TagOutro.
Well, that brings us to the end of this really comprehensive deep dive into the principles of oncology. We've journeyed all the way from Hippocrates noticing a crab and the fundamental Hayflick limit on cell division, through the complex hallmarks cancer cells must acquire, the challenges of staging with TNM, the statistical traps like lead time bias in screening, right up to the power, and the dilemmas of modern, multimodal, molecularly informed treatment and end-of-life care. We've really covered the entire scope laid out in this foundational chapter.
It's a vast amount of information, isn't it? And I think the framework we've built today really underscores a key tension in modern oncology. We have this incredible explosion of knowledge, particularly at the molecular level, leading to ever more complex decision-making. Especially in that adjuvant setting we discussed, constantly trying to balance the small chance of a major benefit like cure for a few against the near certainty of toxicity and burden for the many. That drive for better precision, for tools like ctDNA to tell us who really needs that extra treatment, is absolutely critical going forward.
So, reflecting on everything we've covered, from the cellular level right up to population health, we want to leave you, our listeners, with a final provocative thought. It connects the two ends of the cancer control spectrum. We're developing these incredibly sophisticated, personalized molecular therapies, targeting unique vulnerabilities in an individual's tumor. Yet, at the same time, we know that broad public health prevention strategies tackling smoking, obesity, infections, environmental exposures could potentially prevent the majority of cancers from ever occurring in the first place. So the question is this: considering finite global health resources, what represents the most effective and responsible path forward? Should the main focus be on pouring billions into developing the next generation of highly specific checkpoint inhibitors and targeted therapies for those who develop cancer? Or should the priority be enforcing massive population-wide lifestyle changes and stringent environmental protection measures to stop most cancers before they start? Where does the balance lie?
The challenging question: pitting individualized high-tech medicine against broad public health prevention. Definitely something to think about as you consolidate all this material.
Thank you for joining us for this deep dive. We hope this detailed walkthrough proves useful for your revision and practice. We'll see you next time.